So imagine you're sitting by a lovely stream in a grassy forest. You suddenly hear and then see someone struggling in the water, and so you jump in the water and you rescue them and you bring them to shore. And just as you get to shore, you hear a second person struggling in the water, so you turn and you're getting tired, but you jump in and you rescue that second person and you bring them to shore. And as you're pulling that second person up, all of a sudden you see a third person. And at this point, you're starting to think, why are all these people in the river? And why is no one preventing them from falling in? Population health is one of the newer fields of endeavor in the world, founded just in the last decade. It's related to but distinct from epidemiology and public health because it's interdisciplinary. It explicitly incorporates the healthcare system as well as health policy. And it's concerned not just with the average level of health in a population, but the variation in health across the population, as well as explanations for why health might vary between different groups of people. Here at Rice in our sociology department, we're particularly strong in the area of pop health, that is, the social determinants of health. So population health scientists have consistently demonstrated again and again that one's socioeconomic status, your wealth, your income, and your education, is a fundamental cause of disease. So it seems obvious maybe that the poorest and least educated among us are most likely to be unhealthy, perhaps by greater exposures to unhealthy environments where they live, where they work, where they go to school. But less obvious is that across the centuries, this has been the case. Why, as new medical technologies and drugs are developed, as access to healthcare improves, why do we consistently see a gradient in health such that the wealthy are healthier than the middle class are healthier than the working class, and the working class are healthier than the poor? The insight of population health tells us that as each population health improvement is discovered and disseminated, no matter what it is, those with less resources will benefit less and later. And even when those improvements are finally distributed across society, take the example of clean water in the United States, for example, something else will crop up to take its place, leaving our health perpetually and fundamentally stratified by social class. Now, this sounds very pessimistic, I realize, but it's not so. Instead, population health is a critical frame for understanding how health policies can be most effective. So a few weeks ago, as part of my work with the Urban Health Program, which is part of the Kinder Institute for Urban Research here, I had the opportunity to be in a room with leaders of 17 different health research institutes across the Texas Medical Center. All of us were interested in health policy, and we were discussing some potential areas we might be able to agree on to make recommendations for Houston. One physician in the group was advocating the importance of, quote, everyone knowing their number. And what he meant by that was everyone knowing their cholesterol number. Those of you who know me will not be surprised about this, but I was not able to keep silent in this situation. So I expressed that I felt this was quite a short-sighted idea. So yes, it's important to eat a healthy diet and to exercise. Yes, it is important to know what your cholesterol number is. But to believe that we can fundamentally alter population health by promoting individual solutions and personal responsibility will never work. It won't work because of the ways our health and our access to healthy environments and our ability to make healthy choices is socially stratified. Do we truly believe that an African-American working-class man in the Fifth Ward has the same ability to act on that cholesterol number as a white professional man who lives in West University? I don't think so. Instead, population health calls for broad-scale interventions within the social stratification system itself. It demonstrates that an ounce of prevention is worth a pound of cure. It's always less expensive to prevent a chronic disease than to cure one. It recognizes that policies which improve public education systems, support low-wage workers, increase access to preventive care, and radically improve neighborhoods are the only way to fundamentally alter the distribution of health in our society. It calls, therefore, for the implementation of upstream policies rather than downstream policies. It calls for research to understand why people fall in the river in the first place, which people are most likely to fall in, and for policies which will keep them from falling in. Reorienting how we think about health from the individual level to the societal level is not going to be easy, either for us as a nation or for my colleagues at the Texas Medical Center. But it's absolutely critical for our future that we do so. Thank you.